Hello, good morning, everyone. Good morning, participants and respected judge. So we are here for Gynaecology and Obstetrics case history presentation. First, I would like to introduce us, the organizer, that is me, Meghna, and my co-host will be Subhash and Tenzing. First, I'd like to introduce our honorable judge, Dr. Tulika Jha, ma'am. Thank you, ma'am, for taking your time.
My pleasure, Meghna, my pleasure.
Okay, so I'll quickly repeat the rules. Each participant will get 5 minutes to present their complete case, and any exceeding in the limit might lead to deduction in their marks. And all the after your presentation, ma'am is free to cross question every case. The results will be announced on 11th of October at 7 p.m. During the valedictory ceremony. So we may start now. Subhash, you may take the head, or Tenzing, whoever.
So the first participant is Mrinalini Devi from Government Villupura Medical College. Her case is on normal delivery with underlying condition. You may start now.
Hello, am I audible?
Should I have allowed their case, sharing the screen, right?
Oh, am I audible?
Yeah. You should be able to share their screens.
Hello, am I audible?
Yes, you're audible.
Yes, you are audible.
Do I need to turn on my camera?
You're sharing a screen?
Yes, ma'am. Is my screen visible now?
Hi, your screen is visible. You are visible now.
So, can I start now?
Yes, you may.
Pleasant good evening to one and all present here. I'm Mrinalini Devi from Government Villupura Medical College, here to present an obstetrics case. A 27-year-old female housewife by occupation. Ma'am?
We can't see your slides. Do you have slides?
Yes, ma'am. I'm presenting.
Actually, just saying that it has started screen sharing, but it hasn't actually.
Let it come on the screen, Mrinalini, and then you can start once again.
If you want, then I'll share the screen if you want. Mrinalini, should I share the screen then?
It's showing that it's sharing my screen. One second, I'll try again. Now? Is it visible?
No, Now it's visible. Now it's visible.
I think if I put it as a PPT, it's going off.
So do your slideshow.
Yeah,
now it's okay.
Yes,
just shift us to. Okay, it's perfectly fine
yes,
now.
Can I start now, ma'am?
Your time starts now. Okay.
Pleasant good afternoon to one and all present here. I'm Mrinalini Devi from Government Villupura Medical College, here to present an obstetrics case. A 27-year-old female, housewife by occupation, has an obstetric score of Gravida 2 Para 1 Life 1 with her LMP on February 19, 2020 and her EDD on November 26, 2020. She is reviewing for safe confinement in view of her heart disease complicating pregnancy. 1 year back, she developed palpitations and dyspnea, for which she consulted a cardiologist at Geneva. The echo was done there, and she was told to have valvular heart disease, and she was given medication for 1 week, but she did not go for any cardiology follow-up after that. For this current pregnancy, the initial ANC was done at a nearby PHC, and they referred her to GBMC in view of her heart disease. Here, a cardiology workup was done, and the echo was said to be suggestive of rheumatic heart disease. In the first trimester, she detected her pregnancy by a urine pregnancy test. There's no history of any exanthematous fever or first trimester bleeding per vagina or any UTI. And she also took 2 doses of injection TD and is regularly taking folic acid tablets. The quickening was felt at the end of 5th month, and there is no history of any gestational diabetes mellitus or gestational hypertension. An Omni scan was done at 20 weeks and was reported to be normal, and there is no history of any bleeding per vagina or UTI during the 2nd trimester. During the 3rd trimester, there is no history of bleeding per vagina or gestational diabetes mellitus or gestational hypertension. An USG was done at the 8th month, and the fetus was said to have normal growth. Currently, she is not on any medication. She conceived 1 year after her marriage. The first childbirth was a full-term normal vaginal delivery with a birth weight of 2.9 kg. She had no cardiac symptoms during the antenatal, intrapartum or postpartum period, and she was discharged 3 days after her delivery. She attained her menarche at 13 years of age, and her last 3 cycles were regular prior to her LM. She was been married for past 5 years, and it's a non-consanguineous marriage, and there's no history of any contraceptive use. She was detected to have valvular heart disease in 2019 at the age of 26 years. She had no history of any previous cardiac surgeries, and no history of diabetes mellitus, hypertension, and bronchial asthma. She's currently not on any medication. There's no family history of diabetes mellitus, hypertension, or heart disease, and her bowel and bladder habits were normal and normal sleep habits. After getting informed consent, the examination was started. She was conscious, oriented, and afebrile, moderately built and nourished. Her weight gain during pregnancy was 11 kg. Her JVP was not raised, and her vitals were within the normal range, and her breast, thyroid, spine, and skull were normal. On inspection of the, we saw that there was no elevated JVP. Her chest was bilaterally symmetrical, and there was no precordial pulsations, and the trachea appeared to be in midline, and there was no dilated veins or visible pulsations. On palpation, the apical beat was felt in the left fourth intercostal space, 1 centimeter lateral to the midclavicular line, and there was no parasternal heat. On percussion, the right heart border corresponded to the right sternal border. On auscultation, S1, S2 was normal, with a low-pitched diastolic murmur of grade 2, best heard at the apex, with the patient in her left lateral position, in full expiration with the bell of the stethoscope. There was no radiations and there was no other murmurs. Her respiratory system and CNS were normal. On abdomen examination, the abdomen is longitudinally distended. There's linear nigra and stria gravidarum present. There's no scars or dilated veins. On palpation, the fundal height was 33, corresponding to 33 weeks. On fundal grip, a soft, broad, non-palatable mass was felt at the fundus, indicating the breech, and umbilical grip, uniform resistance was felt on the left side, indicating the fetal back, and multiple limb nodules were present on the right side, indicating the fetal limb. And clinically, the liquor was adequate. First pelvic grip, a round, hard, palatable mass was felt, indicating fetal head, and second pelvic grip confirmed the first. And synciput was felt at the higher level than the occiput. On auscultation, the fetal heart rate was around 158 per minute and regular. On local examination, per vaginum, the cervix was soft, anaphase, single fetus with membranes intact, and vertex was at -5 station, and pelvis was normal. I'd like to summarize by saying a 27-year-old female housewife by occupation with an obstetric score of Gravida 2 Para 1 Lit 1 is reviewing for safe confinement in view of her heart disease. She was detected to have rheumatic heart disease 1 year back with no cardiology follow-up after that. She had no cardiac symptoms during her previous pregnancy. On examination, the apex bell beat was present at the fourth left intercostal phase, 1 centimeter lateral to the midclavicular line, and a low-pitched diastolic murmur of grade 2, best heard at the apex with the patient in left lateral position in full expiration with the bell of the stethoscope was noted, and the fundal height was 33 centimeters, and the cervix was soft and anaphase with a single live fetus, membranes intact, and pelvis was normal. Going on to the investigations, a complete bell count with the peripheral smear to start off, and then urine, albumin, and sugar with her thyroid function test, and an USG abdomen pelvis, and echocardiogram and ECG are to be done. Thank you.
Thank you so much, Mrinalini Devi. Ma'am, would you like
Thank you,
to ask some
Mrinalini.
questions?
Continue. I'll ask. You can continue. Is it Subhash?
Yes, ma'am. Ma'am, it's
Okay,
your
you can.
turn too.
Okay, I'll just go through the slides once more. Mrinalini, can I just a quick look through the slides
Yes.
once more?
Is it visible now?
It is. Can you put it in
Yes, ma'am.
slideshow mode? Okay. Next slide. Next slide. Next slide. Next slide. Next. 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 Okay. Next. 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 Okay. Next. 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 Okay. So, can I go on to the questions now?
Yes, ma'am. Sure.
Okay. First question is, nice presentation, Mrinalini. Let me congratulate you first. It was nice and concise. But I have a few questions. First is, you said she had some sort of a rheumatic heart disease. The echo also said. Didn't the echo mention what was the valvular heart disease?
Oh, ma'am.
Because usually they...
Yes, ma'am. She didn't have the reports, ma'am. It was only based on the history that she said.
Okay. So from your examination, what do you think could be her heart disease?
From my examination, since there's a diastolic murmur, ma'am, and I'm probably guessing rheumatic heart disease, ma'am, with mitral stenosis as the most probable.
Mitral stenosis. Okay. Now, didn't she have any complaints during her first pregnancy? This was the first time. So
First
what is the
pregnancy was normal.
first pregnancy was normal and there was no problem. So she was not diagnosed as a case of heart disease then, right?
No, ma'am.
What do you think? Is it probable? Can this happen? Does this usually happen? Because what is the main period of life during which rheumatic heart disease occurs, or a patient has rheumatic fever?
Rheumatic fever is around the younger age group, ma'am, from 5 to 10, 15 years old. And recurrent infections can cause cumulative damage to the valves, ma'am. And it usually presents, the valvular heart disease usually presents in her 20s or 30s, ma'am.
And so by that logic, she should have had some complaints during her first pregnancy also. So maybe for some reason she did not go to the doctor or was not diagnosed. Now, if a person has a heart disease, valvular heart disease, especially mid-diastolic murmur and suppose mitral stenosis, won't she be what medicines should she be taking?
She should be counseled, ma'am. Even before conception, she should be counseled regarding the possible complications that can arise during the pregnancy. And in the antenatal period, she should be...
What are the complications of mitral stenosis?
When she gets pregnant, there's an increase in cardiac output and an increase in blood volume, ma'am. So it can worsen the lesion by causing a pulmonary edema, ma'am, or congestive cardiac failure.
Okay. So, do you think some medicine should be given to, so that, because as you mentioned, in the body, so routinely given to a patient with valvular heart disease?
Sorry, ma'am, I couldn't...
Huh. What medicine you mentioned she was not taking any medications, but do you think she should have been on some medication? What I mean is, usually a person with heart disease is prescribed some medications.
Yes, they're usually on penicillin prophylaxis, ma'am.
Exactly. So
penicillin
and penicillin prophylaxis and some diuretic also.
Yes, ma'am. To prevent if the acute pulmonary edema, furosemide can be given, ma'am.
Exactly. Okay. Now, just another question. You wrote fundal height 33 weeks. How did you measure 33 weeks? In one of...
Yes, ma'am. Corresponding to 33 weeks, ma'am.
What is...
Yes,
per abdomen, we have 24 weeks, 28 weeks, 32, 34. Yes, so I think here you should... when you're writing in centimeters, you can write any figure. But yes, when you're measuring in height, weeks is usually 32 or 36. Yes, you can write 32 to 36 weeks, right? Yes, now, in the examination thing, go to your examination slide, investigation slides. What are the routine investigations in a pregnant patient, and what are the special investigations you need to do for this patient?
So, for a routine pregnancy, starting in the first trimester, we have to get a complete blood count with a peripheral smear, ma'am, to rule out any underlying anemia, and we have to
just name the tests.
Yes,
just name the tests. Which are the routine tests?
Yes, ma'am. Complete hemogram with peripheral smear, and then urine, sugar, and albumin, and pelvic ultrasound for the fetal well-being, ma'am.
Blood group and RH typing.
Blood group typing, yes, ma'am. And
serology.
If she has any for BDRL and HIV, ma'am.
Hepatitis B, C, and HIV. Okay. And special tests for this patient?
We have to rule out any thyroid disorder, ma'am. So thyroid function test and echocardiogram with an ECG, ma'am.
Okay. Last question regarding management. Since she had a previous normal delivery, what are you planning to do this time?
So far, she doesn't have any symptoms, ma'am. So
What
upfront,
symptoms?
like
Symptoms
dyspnea,
of?
symptoms of cardiac failure, ma'am.
Okay.
Like dyspnea or fetal edema or
You
hemoptysis.
also have to think of arrhythmias also.
Yes, ma'am. And she doesn't have any symptoms. We'll be asking her to review every 2 weeks, ma'am. And at 36 weeks, we'll admit her, ma'am.
Then?
We have, and then once she gets into labor, ma'am, first stage of labor, we have to make sure that she's propped up and she isn't straining too much. And we have to give nasal oxygen if needed, ma'am. And we have to give limited IV fluids.
Okay. And what would help you in taking the decision of a cesarean section? When would you go for a elective cesarean section in a heart disease patient?
Yes, ma'am. Elective cesarean section if the patient has Eisenmenger syndrome or if it is a Marfan's disease with dilatation of the root of aorta or any aortic regurgitation with dilatation of the root of the aorta and any cyanotic heart disease which have not been corrected now. In those cases, we go for an elective.
In mitral stenosis also, the area, valvular area becomes important. Okay, so we actually, so we have to stratify the patient according to the risk and then take the decision. Okay, Mrinalini. Thank you. Okay.
Thank you so much, ma'am, and thank you, Mrinalini. Should we move to our next contestant?
Sure.
Thank you.
So the next contestant is Melvin Mabin from Hassan Institute of Medical Sciences. His case is on abnormal uterine bleeding.
Hello. Am I audible now?
Yeah, you're audible and visible.
Yeah,
you can share your screen. Sure. Take your time.
Is it visible now?
Yeah, it is visible. Yeah.
Okay. Can I start, ma'am?
Just let me see the time. Okay, 3:21, 3:22. Okay.
Good afternoon, ma'am. Good afternoon, everyone. I'm Melvin Mabin, final year MBBS from Hassan Institute of Medical Sciences. Today, I'll be presenting the case of a 35-year-old lady, Mrs. XYZ, hailing from Shantigrama, Hassan. She is a housewife by occupation and belongs to class 4 of modified BG Prasad scale. She was admitted to the hospital on 12th February 2020 and examined on 15th February 2020. Her last menstrual period was on 6th February 2020 and her obstetric score is para 2 and living 2. Her chief complaints include heavy and prolonged menstrual bleeding since 3 months and lower abdominal pain during menstruation since 3 months. History of presenting illness. The patient was apparently all right 3 months back. Then she noticed heavy bleeding during menstruation, which lasts for 8 to 10 days in a 30-day regular cycle. She uses 7 to 8 pads per day. She also complains of passage of clots. She also complains of pain in the lower abdomen since 3 months. The pain starts 1 day before menstruation and subsides after menstruation. Pain is of dull aching type and non-radiate. No history of intermenstrual bleeding, no history of abdominal distension or pain during intercourse, no history of fever or discharge per vaginum, no history of difficulty in micturition or difficulty in passing stool, no history suggestive of thyroid dysfunction, no history of intake of oral contraceptive pills, no history of IUCD insertion, no history of loss of appetite or unintentional weight loss, no history of fatigue or palpitation. Menstrual history. Her past cycles, she attained menarche at 13 years of age. Her past cycles are regular and normal. Present cycles are of 30 days with 8 to 10 days of flow, 7 to 8 paths per day, and no history of dysmenorrhea and passage of clots are present. Obstetric history, she is married for 15 years, para 2 and living 2. Her first pregnancy was a full-term vaginal delivery, a male child who was 14 years old and well. Second child was a male child, full-term vaginal delivery of 11 years. There is no history of any contraceptive usage currently. Past history, she is not a known case of diabetes, hypertension, epilepsy, asthma, TB, or thyroid disorders. No history of hospitalization or surgeries in the past. No history of blood transfusions in the past. Family history, no history of similar complaints in any of the family members. No history of any bleeding disorders in the family. Personal history, her diet is mixed, appetite is normal, sleep is undisturbed, bowel and bladder movements are normal, and there is no history of any addiction. Summary of the history, a 35-year-old lady with a para 2 living 2 with no comorbidities and no past history comes with chief complaints of heavy and prolonged menstrual bleeding with passage of clots since 3 months and pain during menstruation since 3 months. I would like to examine the abdomen. General physical examination. Here is a middle-aged lady who is moderately built and well-nourished, conscious, cooperative, and well-oriented to time, place, and person. Her BMI is 29.29 kgs per meter square. Mild pallor is present. No other complaints. Breast, no other findings. Breast, thyroid, spine, and skin are normal. Her vitals, pulse rate is 76 beats per minute. Blood pressure 120 by 80 millimeters of mercury. Respiratory cycles is 16 cycles per minute. Temperature is asexual. On per abdomen examination, shape of the abdomen is flat, umbilicus is central and inverted, all quadrants move equally with respiration, no scarce sinuses, dilated veins or visible palpation seen. Hernial orifices are intact. On palpation, there is no local rise of temperature. It is a mass corresponding to 20 weeks gravid uterus size is palpated in the hypogastric region with firm consistency, regular borders, smooth surface, and lower border is not palpable. The mass is mobile from side to side and it is non-tender. Percussion, dull note is heard over the mass, no free fluid noted. Auscultation is normal. Per vaginal examination was not done. Systemic examination, the examination of the other systems are normal. Summary of the case, 35-year-old lady presents with heavy and prolonged menstrual bleeding and dysmenorrhea since 3 months. On examination, a firm and non-tender mass of 20 weeks gravid uterus size is palpated in the midline, mobile from side to side, probably a case of fibroid uterus. Differential diagnosis, polyp, adenomyosis, leiomyoma, malignancy, and endometrial hyperplasia. Provisional diagnosis, it is a case of abnormal uterine bleeding, probably due to fibroid, which comes under AUBL. Investigations, blood investigations, hemoglobin, bleeding time, clotting time, complete blood count, prothrombin time, urine pregnancy test, transvaginal sonography and color Doppler, MRI, and endometrial scan. Thank you.
Thank you, Melvin. It was a very nice presentation. Can I ask a few questions now? Can I move on to the question?
Yes, ma'am.
Yes, ma'am.
Okay. Okay. Melvin, so yours was a case of fibroid uterus. How
Yes,
will you confirm your, clinically you think it was a fibroid uterus, so how will you confirm your diagnosis? Because you have also, you have a differential list of differential diagnosis.
Yes,
so
I'd like to proceed by doing an ultrasound. So
okay.
on the ultrasound, it will be, we can see a hyperechoic or hyperechoic mass, which will be uniform and of a smooth consistency. So, and then we'd also like to rule out the other causes of abnormal uterine bleeding in this age group.
So basically by ultrasonography, you're going to confirm the diagnosis. Now, one thing in your list of differential diagnosis, I think, I know the history doesn't suggest, but I think pregnancy should also have been there. And another is chronic retention of urine, because many a times fibroid leads to difficulty in urination, and there may also be, a somewhat distended bladder also. So just keep it in mind next time. Now, I know you're prepared for the question. Still, I would like to ask that what are the different causes of AUB?
AUB is classified according to the palm coin classification. So we have polyp, adenomyosis, leiomyoma, malignancy, and hyperplasia. So these are the structural causes. Then you have the functional causes in the form of coagulopathy, ovulatory disorders, endometrial disorders. Then you have iatrogenic causes and the unclassified causes, which are not coming under.
Can two causes be present at the same time?
Yes, ma'am. We can have
so how will you differentiate? So how will you see the polyp, adenomyosis, leiomyoma, malignancy? So how will you differentiate between these causes?
Ma'am, first like I said before,
the ultrasound will help. First.
Yes, ma'am. And in case there is doubt between fibroid and adenomyosis, we can go forward for an MRI. Then polyp, polyp also will be differentiated on the ultrasound itself. For ruling out endometrial hyperplasia and malignancy, we'll have to do an endometrial sample.
Okay. Now, how will you differentiate? Won't you go for Pap smear, Pap smear?
Yes, to rule out
I think that should also have been there in the list of investigations, because that is, first of all, it should be done routinely, and more so in a case of abnormal uterine bleeding. So Pap smear should also be there. Now, tell me, what are the different types of fibroids?
Ma'am, the FIGO classification has classified into 8 classes. So type 0, 1, and 2 are submucous fibroids. Type 3 and 4 are intramural fibroids. Type 5, 6, 7 are subserous fibroids. And type 8 are non-uterine fibroids like broad ligament and cervical fibroids.
So what, by the reports, what do you think was was the type in this case?
Ma'am, it was probably a submucous fibroids because the history and the history points out more towards submucous fibroids.
Okay. Now, why does the history point more towards the submucous fibroid?
Ma'am, because in submucous fibroid, history of bleeding, like menstrual bleeding, and is more common. Whereas in the other, like subserous fibroids, you have pressure symptoms mainly, like retention
no,
of
not necessary. That is, pressure symptoms are commoner in cervical fibroid. But if but other fibroids, especially intramural and submucous, obviously, may cause bleeding problems. Subserous is something which may not cause bleeding problems. Another thing is, if you think of submucous, I think in your slide I saw it was written no intermenstrual bleeding.
Yes,
but in a submucous fibroid, that is one very important finding. Okay. Now, she is a 35-year-old lady.
Yes.
And you have just diagnosed a fibroid. It's quite big by the look of it, by examination and ultrasound. And she also has symptoms. Now, how will you manage this case?
Ma'am, first for management, we'll do all the investigations. Once we get our report, then we will go forward with probably surgery, because it's quite a large fibroid and symptoms. So I would like to do a myomectomy for the patient.
Okay. Now,
she is a young patient.
Yeah. Okay. Now, suppose the patient is not willing for surgery, then?
If she is not willing for surgery, then we have options of medical management.
Like?
We can either give...
What are the different options?
Yes, ma'am. First, to control the bleeding, we have certain options, but they do not reduce the size of the fibroid, like tranexamic acid, OCPs, and progesterone. If you want to reduce the size of the fibroid as well, then you can go for estrogen antagonist or progesterone antagonist, like you have GnRH analogs, or you can go for selective progesterone receptor modulator like ulipristal or mifepristone.
And any minimal, minimal invasive thing which can be done?
Laparoscopy can be done.
No. What I mean is, you must have heard of uterine artery embolism,
but,
embolization.
It is done in women who do not want to retain the reproductive function.
So yeah, she's 35 years. Her family, I think, is complete. She has to. So I think that part. That is. And have you heard of MRG?
Yes, ma'am. Magnetic resonance
MRUS?
guided high intensity.
MRGUS? Yeah. So
Yes.
that is also. So when you have this question in the exam, so you may have a question, conservative management of a fibroid. So you also have to mention that. Okay. Now, I think it's you answered well. So thank you, Minmin. I think I don't have any other questions.
Thank you so
Thank
much.
you so much, ma'am.
Oh,
Thank you so much.
Thank you. Okay.
Thank you, Melvin. Ma'am, should we move to our last presentation?
Yeah, sure.
The last presentation is by Neha Rathodkar from BJ Government Medical College on abnormal uterine bleeding as well.
Okay.
Good afternoon, ma'am.
Good afternoon. Neha.
1 second.
Take your time. No problem.
Ma'am, is it visible?
Yes, it's visible and you're audible as well, Neha.
Okay. Should I start, ma'am?
Yeah, I think you can.
Yes. Okay. Good afternoon, everyone. This is Neha Rathodkar, final year MBBS student from BJ Government Medical College, Pune. So I'll be presenting the case on abnormal uterine bleeding. So this is the case of a 22-year unmarried female named XYZ hailing from Hadapsar, Pune, who works as a teacher belonging to class 3 according to the BG Prasad scale. She had her last menstrual period on 8th of February 2020. She was examined on 1st of March 2020. She presented with chief complaints of pain during menstruation since 1 year, heavy menstrual bleeding for 6 months. The patient was apparently all right 1 year ago, after which she developed pain during menstruation in the lower abdomen. It was insidious in onset and gradually progressive. It was dull-aching in nature, present throughout the day, and it radiates to back and thigh. It aggravates 3 to 4 days before the menstruation and is relieved on medication. It also reduces after stoppage of bleeding. She also complains of heavy menstrual bleeding since 6 months, regular 28-day cycle with 7 to 8 days of flow, and she uses 6 to 8 sanitary napkins per day. She complains of waking up at night in order to change her pads. There is no history of any passage of cloth. She has no history of abdominal distension, intermenstrual bleeding, burning micturition, increased urinary frequency or urinary retention, no history of constipation, vaginal discharge, fever, cough, or any significant weight loss. Previous menstrual history, she attended menarche at 12 years of age. It is a regular 28 to 30 day cycle. She uses 2 sanitary napkins per day. Flow is for 4 to 5 days. There is no history of any passage of clots or no history of dysmenorrhea. Past history, she has no history of medical interventions, major surgery, diabetes mellitus, hypertension, tuberculosis, asthma, epilepsy, and thyroid disorders. Personal history, she consumes a vegetarian diet, appetite is normal, bile bladder habits are normal, adequate sleep, no history of any addictions. So this is a 22-year-old unmarried lady with no comorbidities and no significant past history who has came with the chief complaints of pain during menstruation since 1 year and heavy menstrual bleeding for 6 months. On general physical examination, the patient is conscious, cooperative, and well-oriented to time, place, and person. She is moderately built and nourished. The BMI is 21.3 kg per meter square. She has got mild pallor. There is no icterus, cyanosis, clubbing, generalized lymphadenopathy, or edema. Her temperature is 97.4 degrees Fahrenheit. Pulse is 70 beats per minute, which is regular in rhythm, normal in character, no radial or radiofemoral delay. Peripheral pulses are bilaterally and equally palpable. Respiratory rate is 20 per minute. BP is 120 by 80 mm of Hg in right upper limb in supine position. Abdominal examination, the shape of the abdomen is flat. Position of umbilicus is central and inverted. Corresponding areas move equally with respiration. No scars, sinuses, or dilated veins are seen. Hernial orifices are intact. On palpation, there is no local rise in temperature. Tenderness is present in the iliac regions on both the sides. Abdomen is soft, no palpable mass, no organomegaly. On percussion, a tympanic note is heard. Lever dullness heard at the right fifth intercostal space. Auscultation bowel sounds were heard. Other systems, cardiovascular system, S1, S2 sounds were heard. There were no any murmurs. Respiratory system, normal vesicular sounds heard, no added sounds. Central nervous system, there was no any focal neurological deficit. Provisional diagnosis, 22-year-old unmarried lady who came with chief complaints of pain in abdomen since 1 year and heavy menstrual bleeding since 6 months with tenderness in the iliac region on both the sides, which is suggestive of abnormal uterine bleeding due to some ovulatory disorder, AUBO. So these are my differential diagnosis: endometriosis, endometrial hyperplasia, endometrial polyps, leiomyoma, adenomyosis, malignancy, and coagulopathy. Investigations, I would like to do a urine pregnancy test, complete hemogram, BT, CT, PT, APTT, thyroid function test, transabdominal ultrasonography, diagnostic laparoscopy would be the investigation of choice. So thank you.
Thank you, Neha. It was a nice presentation. And now, do keep the slides over here, okay? If I need to see any one of them.
Okay, one second.
Okay. She's 22 years old, I guess.
Yes, ma'am.
And just can you go to the menstrual history slide just once more?
Ma'am, previous menstrual history or now? Okay, this is the previous one.
Previous and the current one?
Ma'am, currently she has heavy menstrual bleeding from 6 months. It's a regular cycle, 7 to 8 days of flow, and she uses 6 to 8 sanitary napkins.
Okay. So my first, according to you, you think it is AUBO, right?
Ma'am.
So if you think it's AUBO, will she be having 28-day cycles, regular cycles? What usually if a patient is having AUBO, what are the usual?
Yes, ma'am. In AUBO, there can be both types.
That is the usual menstrual pattern.
Yes, ma'am. Mostly there are anovulatory cycles, but there also can be ovulatory cycles, like in this case.
Okay. So then what do you think could be the likely cause? If she's having normal ovulation, then what do you think could be the likely cause for heavy menstrual bleeding?
Ma'am, most probably this is
in this age group.
Yes, ma'am. Endometriosis is quite common in this age group, ma'am. So most probably she is a case of endometriosis.
Okay, but what is the commonest cause of AUBO in a younger age group?
Ma'am, it could be PCOD.
Actually, PCOS, polycystic ovarian syndrome, is a commoner cause, right?
Common cause.
So, in which there are usually delayed periods, and after once she starts bleeding, she has heavy periods. Correct?
Ma'am, there could be also benign tumors could also be there.
Okay. Okay. So now, how will you diagnose the case? What are the investigations? I saw the list. Do you want to do any special investigations since you are labeling it as AUBO?
Ma'am, there is a biochemical marker that is CA125, which could be done. But it is a non-specific marker again.
No, but in ovulatory cycles, if it can only be done, it needs to be done only if there is endometriosis firstly, and if there are any ovarian lesions. Suppose she does not have any, then why will you go for a CA125? I think just one thing, your presentation is very nice, but because of the cause, I think the cause you should have tried to show some other cause, okay? Because in a 22-year-old, that is very important. Now, secondly, she was an unmarried girl, but I think another history is very important. Regarding what, can you guess what I mean? You should have taken contraceptive or use of any emergency contraception.
No, ma'am, nothing.
Or no any sexual contact or sexual history? Oh, there's no such history. Okay. Then I guess you have to go for ultrasound and see whether she has endometriosis or not. Okay. Now, how will you treat this patient? How will you manage her?
Ma'am, firstly, she has to be managed for her bleeding because she has heavy bleeding and the pain. So firstly, for the pains, I would try with NSAIDs. And then for the bleeding, I would go
NSAIDs? Which NSAIDs would you prefer? NSAIDs,
ibuprofen or anything.
For the pain?
Yes,
which molecule would be? Okay. And then, so
And
if
for the bleeding,
NSAIDs,
yes, ma'am. Sorry.
bolo, no problem, bolo.
Yes, ma'am. For the bleeding, I would like to go. If she has anemia, then blood transfusion can be given. Or to reduce the bleeding, you can give tranexamic acid, or the progesterone analogs can be given. Medroxyprogesterone acetate can be given.
Okay. And for the pain?
Ma'am, pain, any NSAIDs could be given.
Okay. And suppose you go do an ultrasound and you see there is bilateral chocolate cysts.
Okay.
And CA125 is also slightly raised. What will you do then in a 22-year-old unmarried girl?
Ma'am, she has to be counseled for it, of course, because surgery is the only option in the chocolate cyst.
But the size is important. Surgery can be avoided if the size is less than 4 centimeters.
4 centimeter, then we could go with
So go
conservative
for
management.
medical management. And if it's
Yes.
more than that, then we go for surgery.
Yes.
Okay, Neha. That would be fine. Okay. Thank you.
Thank you, ma'am.
Thank you so much, Neha. Thank you so much, ma'am. Now we have come to the end of this presentation.
Yeah.
Ma'am, we would like to thank you for, it was like, we are honored to have you here. And
it was my pleasure entirely. And I also I'm feeling good to be able to participate on this online competition. Last year, I had a talk in Arjikar Medical College, I remember, for the SAMSACON.
Yes, ma'am.
Scientific
paper writing, ma'am.
Meghna, are all of you from Arjikar Medical College?
Yes, ma'am.
Subhash, yes.
Yes,
Yeah,
ma'am.
Subhash
Yes.
face, I know, I recognize his face. And Tenzing also.
Yes, ma'am. Yes, ma'am.
Anirudh is also here now.
Oh, Anirudh is also here. So why didn't all of you participate, or at least one of you four? No papers from Arjikar Medical College? You should.
Yes, sir. Ma'am, this for gynae especially, it was open for only the final years. We are.
Oh,
ma'am, first is
okay. Then it's okay. Thank you very much. So we can end this session now, and
Yes,
I'll mail the mark sheets. Okay, I'll mail or WhatsApp you the mark sheet. Okay.
Okay, ma'am. Okay.
Thank
Thanks
you.
a lot, ma'am. Thank you.
Thank you.
To all the participants, the feedback form has been shared. Please look at it and send us your feedback. And the feedback form has also been shared on the YouTube live stream. Thank you so much for joining in. I'll be ending the session now.